Hey there, it's Thursday, Dr. Soloway. It's a tired, sleepy Dr. Soloway after patients on Thursday, and we're going to talk about Sjogren syndrome. Everybody thinks Sjogren syndrome simply means dry eyes and dry mouth. Well, let me tell you a little bit more about Sjogren syndrome. Sjogren syndrome, which is an exocrine gland dysfunction, which means tears, saliva, nasal, skin, vaginal, rectal dryness or secretion are decreased. When it's all decreased, we refer to this as pan, P-A-N, pan dryness. So pan dryness is a feature of Sjogren syndrome. However, one needs to exclude other causes of dryness such as dysautonomia, dehydration, anemia, and other conditions. So what makes us think about Sjogren's, and what should we think about while we're evaluating a patient either for Sjogren's or with Sjogren's? So Sjogren's disease is an autoimmune disease, as I said, of the exocrine glands. So for example, it may involve your pancreas, but it would not involve your insulin. It'll involve the digestive hormones. The exocrine glands are the glands that will produce a liquid that will come outside the body, while the endocrine glands make hormones in the body. So here we go with a little bit more on the clinical side. It is a connective tissue disease. It is associated with positive ANA, SSA, SSB, and rheumatoid factor. That combination is the classic quartet of blood test positive in Sjogren's. However, other combinations can exist, and those are not the diagnosis. And if a person has ANA, rheumatoid factor, SSA, and dry eyes and dry mouth, they could easily have rheumatoid arthritis or lupus. So how do we tell the difference? Well, difference number one is a salivary biopsy. The minor salivary gland is biopsied, and the lymphocyte score of greater than 1 is diagnostic of Sjogren's, along with staining of the cornea, which is something done by a specialized eye doctor. And the two stains I like are either rose bengal, which is a little bit uncomfortable for the patient, or lysine green. Should either of those be abnormal, that'll indicate that there's chronic dryness with scarring perhaps, and that along with a lymphocyte score greater than 1, this is something that would be suggestive of Sjogren's. Now, if somebody has ANA, SSA, SSB, and rheumatoid factor with either one of the other two, that person has Sjogren's. Okay, why is it important to differentiate Sjogren's from, let's say, lupus? Well, if your platelet count is low in Sjogren's, it's because you've got a big spleen and the spleen is eating the platelets. If you've got a platelet count that's low in lupus, it's because you have antibodies that are actually eating the platelets, and therefore the treatment would be different. Now, for those of you with Sjogren's who are taking Plaquenil, which is hydroxychloroquine, it's not indicated. It is indicated in lupus and occasionally in rheumatoid arthritis, but it is not indicative of use, or it is not indicated for use in Sjogren's syndrome. There was no data to support that, and doctors prescribing it are merely treating themselves and not helping the patient. Sometimes the doctors do like to treat themselves in hopes that they feel they'll make the patient happy because something is being done as opposed to nothing being done. Okay, so other things that occur in a Sjogren's patient besides dryness, one would be shortness of breath or cough, which would indicate interstitial lung disease. So the Sjogren's patient often needs a CAT scan of the chest. Sjogren's patients do have mouth dryness and therefore have difficulty swallowing. Therefore, an evaluation of the esophagus or stomach is often indicated to look for delayed gastric emptying or trouble with the esophagus. Additionally, patient with Sjogren's gets central nervous system or brain and or spinal cord involvement and can act in any one of many ways, such as depression, anxiety, psychosis, encephalopathy, or any other organic brain syndrome, which essentially means there are personality changes, stroke-like features, paralysis, weakness, burning, tingling, numbness. So you need to ask your Sjogren patient, or if you are a patient, you need to wonder if, I wonder if my neuropathy or peripheral neuropathy or small fiber neuropathy is linked to Sjogren's. So neuropathy, interstitial lung disease, brain involvement, abnormalities of blood counts, such as the platelet example that I just gave you, enlargement of the liver and spleen, increased pH in the urine, or what can be referred to as renal tubular acidosis. Any of these, along with arthritis and so-called constitutional findings, such as feeling unwell, fever, chills, night sweats, these are all seen in Sjogren's and need to be looked for. Furthermore, there's a higher incidence of lymphoma in Sjogren syndrome, significant elevation. And if somebody has a rapidly elevating protein, and if they have what is referred to as a monoclonal protein, which would be a spike or an increase in IgA, IgM, IgG, or kappa light chain, or lambda light chain, or cryoglobulins, these should all send a red flag to look for a conversion to lymphoma, which would be treated differently. We currently do not have a specific treatment for Sjogren's. We do use methotrexate, low-dose steroid, Salogen, and Restasis for dry mouth and dry eyes. There are substitutes for these depending on your insurance coverage, and I hope this finds you well. This is my summary and a little bit of pick up on Sjogren's. For those of you who have not heard me speaking of Sjogren's in the past, I don't think I've put out a lot of decent information prior, so hope everyone has a nice weekend. Thank you.